Our topic is osteoporosis, pathology, assessment, and management. My name is Jody Gutkin. I have been a physical therapist for 28 years, as well as involved in physical therapy education for over 20 years, and I look forward to presenting this topic and discussing it with you today. The focus of our course is osteoporosis. We're going to spend time looking at the pathogenesis of this condition and the etiologies. And as we work through the content, I do want you to expand your focus on who our population are that may present with osteoporosis as we look at the different etiologies. We'll also look at diagnostic tests, pharmacologic management, and then our therapeutic considerations when we're performing rehabilitation with our patients. All the information that we cover in the course is based on the current research on this topic. We'll look at treatment considerations as well as advances in research and management related to diagnosis, pharmacologic management, and our rehabilitation. To accomplish that, our goals and objectives are aligned. During our first hour, we'll spend time looking at the physiology and pathogenesis so that we understand the disease process as we look forward to management and therapeutic considerations. In our second hour, we will look at diagnostic tests, fracture management, and assessment tools. And then during our third hour, we are going to take time to discuss the specific pharmacologic management as well as our therapeutic considerations. Any tools that I mention or key resources that I mentioned during the course are listed at the end of your course notes packet so that you have those links available as reference during your clinical practice. As with any course that you attend, when you go back into the clinic to apply this information, you're going to do so in accordance with the federal, state, and professional regulations where you practice. As you watch our presentation today, you'll notice that several of the slides have this red icon. It'll be on the bottom right corner. It says, "Consider this." That's to let you know that those particular slides have key information that will be helpful when you go to complete the course post-test later on today. We'll start with a little bit of data related to our topic of osteoporosis. The U.S. Preventative Services Task Force puts recommendations out related to many different conditions and specific for osteoporosis. The data is very concerning, but it also highlights opportunities for us as clinicians to help our populations. The prediction is that we currently have about 12.3 million individuals over the age 50 with osteoporosis, and almost a third of those individuals who sustain a hip fracture will pass within 1 year. Interestingly, osteoporotic fractures, we know, are common in women. However, men do present with osteoporosis, and unfortunately, it is more fatal for them. So we're looking towards, as we consider our different populations that we work with in the clinic, I want you to frame this discussion today, not only of that typical older postmenopausal female, I also want you to consider all your patients that may present with the conditions we're going to discuss who may be at risk for future development of osteoporosis. Also, if you do community outreach, we'll hit on a lot of topics where you have opportunities to help intervene with managing this condition. Looking at a review of our basic bony architecture, we are going to start. Most superficially, we have our periosteum. This is that fibrous layer of our bone where we have our connections for our tendons and our ligaments. It's able to endure those forces of pull from those tendons and our ligaments. Our next deeper area of the bone is going to be our compact bone. You'll also hear this referred to as the cortical bone. This is the region where we have these long, slender cylinders that run vertically, and those are to sustain that compressive force along the bone in order to resist forces placed upon it. And we see an image here of an actual slide of compact bone. This is where we're also going to find our osteocytes, our vascular supply, and our nerve to the bone. The deepest layer of our bone is going to be our spongy bone, also referred to as our cancellous or trabecular bone. This region is a matrix of struts that run in different directions. It has that structure in order to really absorb the shock of forces placed upon that bone with different activities. Then we have our endosteum, followed by our medullary canal and our bone marrow. If we look more closely at these different layers of the bone and consider the different bone cells that are present, osteogenic just means that they promote the development of bone. And we are going to see, if we look at a cross section of our spongy or trabecular bone in this image here, what we're going to see in those struts that run in different directions, if we take a cross section of one of them and kind of look inside of it, we're seeing here that there are rings of cells. And we're going to have our osteoblasts located in that area, which are our bone-forming cells. They create that matrix of collagen and deposit the minerals of the bone. Over time, as the bone develops, they become trapped in that bony matrix, and they become our mature osteocytes that are located within our bone. And here we see those osteocytes become more deeply trapped within that bony matrix. And then lastly, we have our osteoclasts. The role of those osteoclasts are to secrete different acids and enzymes in order to dissolve the bony matrix and reabsorb it so that those osteoblasts can build up new bony matrix. And that's a term that we use a lot. We're going to look at it a little more closely because it's important to understand the physiology in this area so that we understand the different treatments and what we're trying to accomplish with our exercise protocols. I'm a big proponent that if we understand the anatomy and the physiology, it allows us to be broader thinking in our management strategies and prepares us for future advances to digest the different research and information that comes along. When we look at bony matrix, we're looking at that trabecular area deep inside the bone, and the function of this area is to give both flexibility and strength to absorb shock. In order to accomplish that, it needs to have a protein collagenous layer in there that creates the scaffolding of that matrix. And then into that, we have different deposits of minerals that actually provide the strength to resist the different forces. That's what allows the bone to be resilient to different activities. In order to do that, we have different minerals absorbed through our diet. Calcium, we know, is one of the most important ones, and that calcium is going to combine in order to form hydroxyapatite, and that will mix with the magnesium. It incorporates into that collagenous scaffolding, calcifies, and then that's what provides the strength and flexibility to our bone to allow it to respond to the different mechanical forces that are applied during activity. As we look at normal bone remodeling over the course of our life, bone is constantly broken down and built back up to maintain a healthy, sturdy structure, and it's going to repair its own microdamage that occurs from the forces placed upon it with different activities. We have a balance here between our osteoblasts, which are forming bone, and our osteoclasts that are breaking down our bone in order to get rid of the weak structural components and have new, stronger bone formed. Our osteoblasts are going to secrete compounds to synthesize new protein network that then becomes mineralized through the process that we discuss. What should happen at different points in time is that those osteoclasts that are breaking down the bone should slow down so that we don't have too much reabsorption of bone. That there needs to be a homeostasis that is reached in the amount of calcium that is located within our circulatory system. And we have two areas to consider. Our bones need to be strong and need to have calcium in them to have their structural integrity. And we also need to have enough calcium in our circulatory system for the functioning of our muscles and our nerves. Our bone provides that reservoir store of calcium where the body goes to pull from if it needs it to supply those other functions. And that's going to be important when we think about all the different conditions that could lead to osteoporosis. We also need to recognize that vitamin D and calcium need to be brought into the body in order to maintain this process of mineralization. Vitamin D plays a critical role, and most of our vitamin D is going to come from sun exposure. That's our D3 primarily. The general recommendation, it depends a little bit on the resource you read, but there's pretty good consistency that somewhere between 50 and 30 minutes of sunlight every day. That means with having significant regions of the body exposed for that absorption, allows for sufficient vitamin D absorption through the skin. And then we also have our dietary intake, and that can be D2 and D3. More commonly, D2 is our dietary intake. It's closely related to different plant origin, and it's absorbed in our intestinal tract. What happens with this vitamin D is it enters our body systems, and it plays a critical role interacting in the liver and the kidneys. The vitamin D is going to stimulate the liver and the kidneys to secrete different hormones that are going to convert that vitamin D into calcitriol, that travels down to the intestines and gives the signal to the intestines to absorb our calcium and phosphorus that's needed. So the vitamin D is necessary to get the calcium and phosphorus absorption for mineralization, and we can't forget that the liver and kidneys play a role in that process, that sequence of events to allow for strong bone integrity. As we look at metabolic bone disease as a broad category, there are many different circumstances that lead to disruption in this normal process to maintain bone strength. Metabolic bone disease is the large umbrella category of disorders, and the one that we're going to focus on today is specifically osteoporosis. Osteoporosis, we know, leads to general decrease in bone quality. It is a disruption in the metabolism that leads to greater reabsorption or breakdown of bone compared to the formation of healthy bone structure. The microarchitecture of the bone then becomes deteriorated. That trabecular area that should serve as shock absorption leads to decreased bone density and mass, and this declining quality over time as the individual continues to participate in different activities leads to increased risk of fracture because the bone is not as resilient for that shock absorption. And these are all terms that we know. This isn't anything new. I think seeing images of actual bones that presents with osteoporosis makes it a little more real. And when we look at these images, the top one here is of a sample of an individual who's 37 years old with normal bone integrity. And our bottom image here is an individual who is 80 years old and presents with osteoporosis. These images are actually from a 1914 medical textbook. And when we compare what happens to the bone over time, just at first glance, we see that bottom image, it doesn't look as sturdy. Some key areas that we see in general are decreased bone mass because we see more spaces in this bottom image. Particularly down here in this region, we see significant areas of loss of bone in the region where stress would need to be absorbed. And you can almost envision, look at how fragile all of that architecture looks. It almost reminds me of fibrous insulation, where if you just ran your finger through it, it would just crumble. And imagine this is what the individual's full weight-bearing force is going through. So it becomes more fragile. Also, when we look at the edge of the cortical bone, it's going to become thinner and it becomes more rigid and brittle compared to the area up here, parallel to that line. So that makes it less resistant to those vertical compressive forces and more likely to fracture also. There are several different types of osteoporosis that we're going to take a look at. In general, we do have risk factors that are fixed as well as modifiable for the development of osteoporosis. Primary osteoporosis and secondary osteoporosis are our two broad categories. When we break down primary osteoporosis, we're going to look at idiopathic, where it develops type 1 in individuals, females who are postmenopause. And then we have type 2, which is called senile osteoporosis, that occurs in individuals through the normal aging process, both males and females. And then when it occurs in children, we have a juvenile form. That's when the primary disease is osteoporosis. Secondary osteoporosis can occur in individuals who are male, female, adult, as well as pediatrics. And this is when there's some underlying disease process that leads to an alteration in that calcium homeostasis and breakdown of bone, or medications that actually contribute to impaired bone metabolism, and then secondarily, the individual develops osteoporosis. We're going to look specifically at these different etiologies. Risk factors for the development of osteoporosis can amplify both primary and secondary osteoporosis, and we're looking at fixed risk factors that the individual cannot change, such as female gender, age, or having a darker complexion. That's a risk factor because with a darker complexion, there is a decreased ability to produce vitamin D from the sunlight because the melanin in the epidermis. Modifiable risk factors are where our opportunities present to be holistic in our treatment of patients, community outreach and education, and then also look for opportunities for outside referrals if necessary. Any individual who has a significantly low body weight, sometimes this is referred to as constitutional thinness, where their BMI is under 19. They don't have forces over time against their bones to develop good integrity to begin with. Caffeine consumption. Excessive caffeine is going to inhibit our osteoblast activity, and it's also going to increase calcium excretion in the urine, so it doesn't have it available in the body system to calcify the bone. And then combine that with our intestines not absorbing as much calcium when we have a lot of caffeine in our system. Smoking and alcohol are going to inhibit remodeling of the bone. And then in general, having a diet where we are not bringing in those necessary components for that bone strengthening process of mineralization. Consider individuals who are lactose intolerant or vegan, even individuals who have food insecurity that just don't have access to an appropriate diet. Our population who is sedentary, I think, is a good opportunity for us to consider those individuals when we're looking at our discharge planning and continued programming for them. Individuals who have a gradual functional decline, maybe our household ambulators or individuals who are at a wheelchair level. They do not have normal weight bearing on their bones, which places them at greater risk of osteoporosis. Someone who has a neurological diagnosis of stroke or spinal cord injury, pediatric patients who are functioning at a wheelchair level or a lower ambulation level, as well as our patients who have spinal stenosis or osteoporosis, COPD with less endurance. If they're walking less and less vertical stress on the bone, that's going to place them at greater risk of osteoporosis, and we'll need to consider that in developing our programs to help be preventative in nature. Smoking, we know, has many negative consequences throughout our body. Specific to the topic that we're discussing today, not only nicotine, but cadmium has been found to have significant toxic effects on our bone cells. There was a 2020 Swedish study that looked at elderly men. They looked at almost 900 men who they followed over a period of 12 to 16 years, well into their 70s and 80s. And they looked at their medical record results, and they did urine samples for the amount of cadmium in their blood. And they found that those that had high cadmium levels from the smoking also had lower calcium levels. They have recognized in the research that there's slower osteoblast production, as well as a poor blood supply to the bone, and they were seeing increased risk of osteoporosis or increased development of osteoporosis in those individuals. They also note that related to estrogen levels diminishing with smoking, that individuals who smoke also tend to have other habits that may not be positive for their overall health and wellness of their bone. They tend to be thinner, not as high of an activity level, poorer diets, and early menopause does seem to occur in females, all contributing to decreased bone quality and increased risk of osteoporosis. Good news is that some of this is reversible if the individual stops smoking and makes other changes. Analyzing specifically type 1 type 1 osteoporosis, when we look at our females who are post-menopause, this is going to be women who are somewhere between 50 and 70 years old, depending on the onset of their specific menopause. This can also be younger females who have had a hysterectomy, particularly before the age of 45, and when the ovaries are removed also. The protective effects of estrogen are lost. Typically what happens is the presence of estrogen is going to inhibit those osteoclasts. It's going to turn them off from breaking down the bone. It doesn't allow them to differentiate as aggressively, so it controls that breakdown process and allows the osteoblasts to build up bone. When a woman is post-menopause or has that earlier hysterectomy or menopause, that estrogen is not present to shut off those osteoclasts, so they continue to break down that bone. And they've also recognized that the osteoblasts tend to be not as effective, and they don't live as long to function to build up the bone. So the cellular changes that we see lead to this imbalance that causes demineralization and decreased density of the bone, particularly in that trabecular bone that should be absorbing the shock. When they look at the rate of bone loss, they find that immediately post menopause is when there's more aggressiveness in this process, and about 3 to 5% of bone is lost every year initially after menopause, but then by years 4 to 8 post-menopause, it tends to slow to only losing less than 1% annually. But if you still add that up, that's a significant restriction in the integrity of the bone. So good opportunity there, particularly early on, to make positive changes with exercise programs and other interventions. Type 2 osteoporosis is senile. This is going to occur in older individuals. It tends to be slow and progressive as we age, both males and females. Our bone quality tends to deteriorate with the greatest level of peak deterioration in that 7th decade of life. Calcium deficiency seems to be a consequence of aging, and this is attributed to decreased absorption of calcium, low vitamin D exposure. Those aging kidneys are less effective in releasing that hormone that tells the intestines to absorb the calcium. So overall, this is going to slow that remodeling rate and the bone formation. The senile or more age-related osteoporosis does tend to affect the trabecular bone, but it also affects that cortical bone thinning in. This is why we see a slightly different fracture patterns. As we look at females, there is more of a prevalence of osteoporosis in women. This is due to several compounding factors. The first one is that rapid bone loss after menopause because of the loss of those protective effects of estrogen. Combine that with, as the woman ages, we have that age-related or senile osteoporosis setting in. So if the individual is losing approximately 5 to 10% of their cortical bone because of postmenopause, and they're losing about 20 to 25% of their trabecular bone, then as we look at the age-related consequences, we're losing about 20% here of both cortical and trabecular bone. Women tend to live longer, so this process continues. If we add up those numbers, that's why we see this significant increase in women of that risk of developing osteoporosis and the prevalence of it. Juvenile osteoporosis I want to highlight because it may not be something that we think of. When osteoporosis presents in children, when there's no other diagnosis that it can be attributed to, the diagnosis is juvenile osteoporosis. It tends to be rare, and it seems to evidence itself around age 7, but it does vary. Some red flags that we may see that would indicate to us, if you have a child coming in with compression fractures of the spine, that's significant kyphotic posture. And if those vertebral compression fractures are not related to any type of high energy trauma, then a consideration might be that it is osteoporosis, because if there is no specific trauma, it's rare for children to have compression fractures in their spine. What happens is they tend to see that this tends to present around age 7, goes into some type of spontaneous remission, but the challenge is during those critical developmental years, because the bone did not form good and have a strong integrity and a good architecture to it, that leaves them at risk for greater risk of osteoporosis later on in life. Also consider that if you have children that present with the osteoporosis, it may not, in these compression fractures, it may not be primary osteoporosis. It could actually be secondary. They're finding that celiac disease does not present itself early on in children, or it may not be very obvious, that one of the indicators of that malabsorption of the intestines might be that they've developed compression fractures. In that case, it would be considered type 2, something just to keep our eye on so that we're kind of step back and look at our patients holistically and see if we need to make other referrals back to the physician if there might be another cause for those fractures. Secondary osteoporosis is going to be related to some type of underlying disease. Most commonly, it can be endocrine disease, gastrointestinal. Another pediatric population to consider, or young adults, are individuals with anorexia or bulimia. It might be an indicator if they are not getting the nutrition necessary to support healthy bones. A red flag might be if they're presenting with the fracture patterns that you would normally see in someone who has osteoporosis. Renal disorders, and then also autoimmune disorders. There's more discussion in the research that there seems to be some relationship between immune and bone, that there is some type of relationship to either antibodies or the inflammatory process. They're trying to figure it out. If you are treating individuals with rheumatoid arthritis, lupus, you might want to consider adding some of the screening tools that were discussed for osteoporosis, just to be on the lookout for that. The research is still trying to figure it out. Looking specifically at endocrine disease, the cascade of events that happens here, first we need to revisit normally what should be occurring related to the endocrine system and our bones. What happens when we have a decrease in our blood calcium levels? If that calcium is not present in our circulatory system for our muscles and nerves to function, that is going to trigger the parathyroid gland and is going to release the parathyroid hormone. Release of that parathyroid hormone is going to trigger the kidneys to hold on to their calcium. It's going to tell the intestines to pull in more calcium. And then it's also going to go to the bone and pull out the calcium from the bone so that we have this present in the circulatory system and the bloodstream to be present for those other vital functions. Once that homeostasis of calcium is restored, the body should naturally shut down this process. The challenge becomes if someone has a condition such as hyperparathyroidism. Let me change my ink color here. If someone presents with hyperparathyroidism, that is going to increase the secretion of the parathyroid hormone. We're going to have a greater influence on this process. If the parathyroid hormone is released, stimulating the kidneys, the intestines, and the bone to pull calcium into the bloodstream, and there really isn't a deficiency in the bloodstream to begin with, it's that disease of the parathyroid hormone overfunctioning, it's going to not have a mechanism to shut off, to recognize that the homeostasis has been restored and stop pulling from the bone. So it'll continue to pull from the bone, leading to that secondary osteoporosis. But the cause is actually that disease of the parathyroid gland. We can also see this similar cascading of events when an individual presents with, grab another ink color here, any condition that is going to decrease the calcium in the blood is going to trigger this sequence of events where the body will release parathyroid hormone to go pull from the bones, leading to that secondary osteoporosis. Gastrointestinal disease can lead to the development of osteoporosis. It comes down to a chronic malabsorption challenge for individuals of both vitamin D and calcium. Individuals who have inflammatory bowel disease, such as ulcerative colitis, Crohn's disease, it limits the absorption of the calcium. Specifically, individuals who present with celiac disease, the protein in wheat causes an autoimmune response, and they're also finding that specifically vitamin D is fat soluble. So when they have this irritation of the intestines, it's going to not only alter the absorption of calcium, but also alter the absorption of vitamin D. On the positive note, they have found individuals with celiac disease, if they go gluten-free, that will reverse this concern. They're also finding that not only is a concern that vitamin D and calcium absorption, but there is not only that nutrient issue, but also we see increase in the mediators that control that balance of bone breakdown and bone production, and they tend to promote the osteoclast activity. So it tends to just naturally favor reabsorption. To manage many long-standing intestinal conditions, glucocorticoids are utilized, and those medications tend to have a negative effect in several different mechanisms on the homeostasis of our bones. So individuals have several different ways when they present with gastrointestinal disease that place them at risk for the development of osteoporosis. Individuals who have a BMI over 30 presenting with obesity, what is recognized is that subcutaneous fat layer tends to sequester the vitamin D. Even if they're getting enough sun exposure to absorb sufficient vitamin D, when it's sequestered under the skin, then it's not bioavailable for the rest of the body, placing them at risk for poor mineralization. If you're working with individuals who have gastric bypass surgery in their past, or you're working in bariatric rehab, we want to be mindful of looking out for osteoporosis, particularly because if we look at the diagram on the bottom right here, when we look at where vitamin D and calcium are absorbed, calcium is absorbed down here in the large intestine. So that tends not to be an issue for individuals who have gastric bypass surgery. The challenge is vitamin D absorption, because when the bypass is performed, the individuals lose this proximal area of that small intestine where vitamin D tends to be absorbed, and it is going to lead to a deficiency. The female athlete triad you want to consider if you're working with females who are presenting with stress fractures. Not only individuals who exercise excessively for recreation or for their work, also consider your active duty military or females that have very physical jobs and they're presenting with stress fractures that just may not fit. You're not sure why that develops. Consider the fact that if they have menstrual dysfunction, there's an amenorrhea or oligomenorrhea is an absence or very low menses for greater than 3 months, places them in a hypoestrogen state, and then their body is almost functioning similar to an individual who is postmenopause, where those osteoclasts are not inhibited and they're breaking down the bone, making it weak. Also, they tend to find, whether it's by choice or just because the activity level is so much higher than the food intake, could be accidental or it might be intentional in an attempt to control body image. But either way, there's decreased vitamin D and calcium present, and now these women present with osteoporosis and are developing the stress fractures. Now, bear in mind, they're finding that women with the female athlete triad, that their bone density is sometimes 10 to 20% lower than healthy athletes of the same age. Chronic kidney disease can lead to mineral and bone disorder. Someone who has diabetes that's long-standing and has developed kidney dysfunction, or other disorders that directly are going to damage the kidney functioning, we're going to see that the kidneys are not able to produce that hormone that will then trigger the intestines to absorb the vitamin D. Over time, the food that the individual consumes, even if it's high in the vitamin D and calcium, the intestines may not be triggered to absorb that, so we don't have homeostasis. Now we don't have calcium in the circulatory system. That parathyroid gland says, oh, we don't have enough calcium. Now it goes to the bone to pull from those stores. So we also have an alteration in that parathyroid hormone level. So we have several different mechanisms that are placing individuals at greater risk of osteoporosis. And we may not look at the individual and have this be obvious, or their lab values may not be obvious showing with it, because there is this body's attempt at compensation to control their levels of calcium and vitamin D. But the reality is the bone is continuing to deteriorate. Also, think of the stature of many of these individuals. They tend to be a little bit heavier if they have lower activity level and they're not going outside as much and they're not as ambulatory, getting normal stresses on the bone to try and encourage mineralization. So many different angles compounding their risk of osteoporosis. This is why renal rickets in pediatric cases is what it's referred to as, or it's sometimes called a silent crippler. Someone who presents with a solid organ transplant, kidneys, lung, heart, they had some long-standing disorder that led to compromise of that system, that through one of the mechanisms we've already discussed, maybe putting their bone at risk. And now they're finding that once they undergo these organ transplants, that the bone turnover biomarkers are different after the organ transplants, that we tend to see more uncoupling of that balance between osteoblast and osteoclast activity that favors reabsorption and breakdown of bone, making them weak. And those osteoblasts that are forming just don't have the same integrity. As individuals with these transplants are living longer, which is wonderful, it also puts them at greater risk of this process continuing and the development of osteoporosis. They may also have impaired mobility because of general compromise, be at an increased risk of falls that increases the risk of fracture of this brittle bone. So important to consider osteoporosis when you're looking at this patient population. Individuals who are taking glucocorticoids to manage different conditions, including chronic inflammatory conditions, the corticosteroids control inflammatory processes, immunosuppressive effects, prednisone, dexamethasone, hydrocortisone are some of the examples. And it seems to be if individuals are taking dosages higher than 2.5 milligrams a day for over 3 months, that it places them at a greater risk of developing osteoporosis. Some diagnoses that may fall under this type of management, where it is necessary for their primary conditions of asthma, gastrointestinal inflammation, other systemic inflammatory types of conditions, we see a cascade of events that while those conditions may be managed, that the risk of osteoporosis increases. And another opportunity where rehab might need to go hand in hand to decrease that risk of osteoporosis. In 2018, the Journal of Molecular Endocrinology wrote a great in-depth article really detailing the analysis of how the glucocorticoids increase the risk of osteoporosis. I'm going to slim it down for us, but that reference is provided if you want to look at it more closely. In a basic sense, the most direct effect is that the long-term use of the glucocorticoids is going to impair the osteoblast differentiation, so they're less effective in creating that new bone formation. And then they're also finding that the osteoblasts tend to go through apoptosis, so they die sooner. And then again, they're not present in order to build up that bone that is broken down. The individual who is still performing activity has normal wear and tear on their bones. So those osteoclasts are triggered, as they should be, to break down the bone in anticipation that those osteoblasts are going to come in and repair it. Unfortunately, the glucocorticoids impair that ability. Secondary, because this is multifaceted, what we see is that these medications are going to decrease the absorption of calcium in the intestines because it just is not as effective in pulling that calcium from the dietary intake. And then the kidneys tend to be pushing out more calcium. So we have the fact then that there's less calcium present in the circulatory system. And here we go again, that low calcium level in the circulatory system triggers the parathyroid gland to say, okay, we need calcium in the bloodstream. Let's go to the bones, pull it from our reservoir. And it increases the osteoclast activity to get that calcium. Yes, great for the other body systems that need it, but at the consequence of bone integrity. On top of that, as if it wasn't multifaceted enough, they've recognized that the glucocorticoids in general increase the parathyroid sensitivity. So they have a lower threshold of tolerance to those fluctuations in calcium levels, and they trigger this sequence of events even more so. The recommendation then is for physicians to be utilizing the lowest level of the glucocorticoid medications for the shortest period of time. Good news being that it can be reversible, so that the architecture of the bone can be restored. Gonadotropin releasing hormone agonist induced osteoporosis. Stay with me. It's not as complicated as it may sound. When a male individual is presenting with prostate cancer, and when females are presenting with endometriosis, those conditions are related to hormone levels. What typically should be happening is that our hormone levels, we know, help control our bone integrity. This condition is referred to when it presents as androgen deprivation therapy, or when someone's on hormone deprivation therapy to manage the cancer and endometriosis. They actually take the medications that put more of those hormones into their system. That's why it's called agonist. So they have more hormones present. Counterintuitive, but what happens is the pituitary recognizes this overstimulation and that there's too much hormone present, even though it's artificially present, and the pituitary downregulates its typical secretion of these hormones. So FSH, LH are going to be suppressed. So we have low levels of the hormones that are causing the problems with the endometriosis and the cancer, those primary conditions that have to be managed. That's great. What unfortunately happens while that is being managed is the body still needs the calcium present, and we tend to see an alteration then, because we have low hormone levels, of that osteoblast and osteoclast functioning, altering the bone matrix, leading to the osteoporosis. And we're seeing that in some conditions, while the primary conditions managed, osteoporosis becomes a secondary concern or consequence. And looking at some of the research on this, there was a study of females who presented with endometriosis. And they found that over a 12-month period, while they were taking these hormones to manage their endometriosis, their pain decreased, their quality of life increased. Unfortunately, when they did bone scans, they found that osteopenia was present just at the 12-month mark. They were already showing significant bone loss. And these are young individuals, to the point where they showed similar bone quality to a female who was 1 month post-menopause. And we need to be aware of individuals that we need to be doing other things possibly in our rehab to help offset this potential decrease in integrity of the bone. Genetic susceptibility, everything that comes out in the research is also looking at, can we recognize this sooner? It is recognized as a polygenic disease. That means there are many different combined actions of several genes. They've recognized that there is that genetic DNA component, and they've started isolating out those genes for postmenopausal women and in juveniles. And then they also recognize that there are epigenetic factors. That means that there are some type of chemical tags that switch these genes on and off. They haven't honed in on exactly what environmentally or lifestyle-wise those triggers are. That's where the research is going to be heading for the future, so we'll keep our eyes on that. The consequences of osteoporosis are what we need to look at also. The concern is that individuals who have that decreased bone integrity are at a greater risk of fracturing. Osteoporosis is considered a silent disease because often individuals do not know it's present until it reaches the point where they have one of these fractures. Osteoporotic fracture is a general term that just means it's fractures associated with low bone mineral density. So all those architecture changes that we've discussed. A term that's a little more specific is called a fragility fracture. And again, you will hear this referred to so many different ways. The terminology that we are looking at is what seems to be utilized most consistently in the research and across the large agencies that put out our standards for management. Fragility fracture is a fracture that's going to occur with an injury or an event that normally wouldn't cause a fracture. They tend to be low energy, so the World Health Organization defines that as a fall from standing height or less that results in a fracture is a fragility fracture because the bone's already deteriorated. This can also be someone just from a cough or a sneeze, that the bone is just too weak to tolerate any excess force on it. What the research is showing is that after one fragility fracture, the individual is at an 86% higher risk of developing a second fracture. And if it specifically is a hip fragility fracture, they're at a 2.5 times the risk of a future fracture. As we look at the different fracture patterns and where these are occurring, the internal matrix is compromised in the bone, so it's unable to sustain the forces placed upon it. The fracture patterns tend to be a little bit different in type 1 postmenopausal versus type 2 senile osteoporosis because we talked about which components of the bone are mostly impacted. On the bottom image here on the right, look at the integrity of this vertebrae. We can imagine that if any force was placed upon it, it would be at a greater risk of crumbling because our vertebral bodies are primarily trabecular bone, and that is what's often most affected in the postmenopausal type of osteoporosis. We're also commonly going to see wrist and forearm fractures. In our type 2 osteoporosis, we're more going to see not only the cancellous bone, that trabecular soft bone, where we will see spine and vertebral fractures. Also, we see specifically the cortical bone is going to be impacted. And we look at the bottom right image here, we can see a deterioration in the cortical bone where there's thinning. So individuals are also going to present with hip and femur fractures, proximal humerus fractures, where that cortical bone couldn't sustain the compressive forces, and we tend to also see more long bone fractures. The concern with fracture-related morbidity, complications, and mortality risk of death is a sequela of events because the individual has the decreased bone strength for whatever reason, whether they have other endurance or balance compromise from concurrent diagnoses or environmental factors. Whatever leads to their fall or their cough or sneeze in the inappropriate position, the individual sustains that fragility fracture. As they undergo surgery, they're at a greater risk of postoperative complications, DVT, wound dehiscence. If they have decreased mobility, they're going to have decreased risk of pneumonia, decubitus ulcers. There's also concern of surgical stabilization failure, that maybe it just isn't holding the bone fragments together well, and this leads to a greater risk of secondary pathology and fracture-related mortality. That's why fracture healing is very important to understand, and physicians and manufacturers spend a lot of time, and research is focusing on looking at better ways to stabilize those fractures. When we have fracture management, imagine that very fragile bone trying to fixate into it. It's often difficult to find good bone to anchor in to get that hardware to grow in and hold. The images that we're looking at here are simulations of a 3D scan of an bone fragment with and without osteoporosis. This is from an animal study, and when we look at the image on the left here, we see, compared to the top and the bottom, the healing that is occurring over time. We see good cancellous bone formation and good mineral density. On the right-hand side, we're seeing huge gaps here on the top and the bottom in the formation of the bone. And we see that when bone heals that's osteoporotic, it does not heal with as strong a mineral density because it was unable to develop that in the first place, and it has a greater load failure, meaning it's not going to take as much force against it to fracture it again. The internal fixation hardware that's used to manage osteoporosis has evolved over time to try and combat these challenges to get better fracture stability and bone growth. It's evolved from the 1800s with nickel and copper to steel in the late 1800s, stainless steel in the 1900s, titanium in the mid-1900s, non-metallic, and now we are currently looking at more biodegradable types of implants that are osteogenic in nature. Fracture management considerations are looking at that the bone is not as responsive to healing, and if you have that opportunity to look at the scans, the way the plates and screws are utilized, for example, to stabilize a hip fracture in someone who has an osteoporotic bone versus not, may look a little bit different. When we have a fracture of bone that has osteoporosis, so on the left-hand image here, we have the fracture through this area. When they go in and stabilize, this x-ray is of an individual who's 87-year-old with osteoporosis. When they go in to plate this, if they put an isolated plate in the area that's very rigid, because we said that cortical bone has already thinned, if the plate has greater rigidity than the bone, that's where the force is going to go. So the bone doesn't get that natural weight-bearing stimulus to heal, and we know it's already compromised. And what they're finding is that when they put a longer plate in, like in the right image here, and they distribute those loads that'll occur during weight bearing across a larger plate, that it allows the bone to have better response, to give better callus remodeling, and it's going to allow, hopefully, for better healing. And the image on the right is that same individual at 3-year follow-up, that she was pain-free, had full mobility in that hip. They're also looking at coding the screws that are placed in different fracture sites. If we look at this osteoporotic bone on the left, the vertebral bodies, imagine trying to fixate into that when it's fractured. There's nothing there to hold on to. Augmentation methods are being developed to utilize different surface coatings on screws and hardware that are going to improve the performance of the implants. The hydroxyapatite, we said, is what is formed to cause that bone mineralization naturally, and they're looking at coating with that so it's more bioactive to allow for better integration into the bone, to encourage more bone formation around the hardware to give better stability. What they're finding is without that, there's more fibrous tissue that forms versus true bony architecture, and that's why it tends to be weaker when it heals, and it's more likely to pull out. So I think of it as, if you have a plaster in your wall and you put a screw in, it can just crumble. You need something better to help anchor it, and that's what they're looking at developing. In the wrist, what I found is a study where they're utilizing magnesium-coated screws. The image on the left here, we see that screw just above the red line that I drew. This was first approved in Germany in 2013 in non-weight-bearing areas, and now in 2015 in Korea, they're expanding to look at more weight-bearing long bone structures. The way the magnesium coating is developed is to be biodegradable. There needs to be a balance between fixating the bony segments and holding them together enough for this already impaired bone to heal, but having the screw deteriorate to be incorporated into the bony matrix, but not too soon where you have shifting of the bony fragments. And that's what they're working on now, that this magnesium alloy on the right, we can see actual scans here. Initially, when it was placed, you could see the full screw. 6 months, you could see a very slight haze here. And by 12 months, it was integrated and there was fracture healing. Vertebral compression fractures are going to be a consequence of osteoporosis. We have the apex of our curves are often where these fractures are going to occur. So between T7 and T8, and then again at that thoracolumbar transition between T12 as well as L1. There are different ways of classifying these fractures. For some individuals, they may be asymptomatic. They do not even realize that they're there. 67% tend to go undiagnosed. They may be attributed to other causes, or it's just very silent because they happen with such minor trauma, just reaching wrong where there's excessive anterior loading, coughing, sneezing, twisting, even just lifting heavy groceries could, in this fragile bone, cause a fracture. So it's asymptomatic. When we look at symptomatic, sorry, I circled wrong there. The asymptomatic types of fractures, when they are recognized first on the scans, they're going to be called a prevalent fracture because they're already there. And then when they do subsequent scans, if you're reading the report, it may be called incident. That means it's after those initial fractures were noted. For some individuals, it might just be a loss of height, and they diagnose this as at least a 20% or 4 millimeter decrease in height is considered a compression, vertebral compression fracture from osteoporosis. What happens as the individual becomes more kyphotic, it's going to restrict lung capacity also, and this is where we need to be aware of other system compromise to incorporate that into our rehab. When you're treating patients who present with general flank pain, so it may be on their side, going into their back, if they're demonstrating a kyphotic posture, decreased respiratory compromise, what happens as the spine becomes more kyphotic because of those fractures, this rib can rub against the iliac crest, creating a pain syndrome. Often it is misdiagnosed as spinal stenosis because the individual's gait pattern will look similar and they are going to have challenges and pain in the same region. So we want to look and make sure that if it doesn't fully fit for Spinal stenosis, particularly when we have direct access, we need to consider if it is this iliocostal friction syndrome with that rib rubbing, and the true cause is osteoporosis, where they may need additional management. The focus when the patient presents with this is encouraging that spinal extension to work on respiratory status as well as alignment with all functional activities. Different classifications of spinal fractures are going to exist. The Donat classification goes a 1 through 3, looking at the height loss of the vertebral body. Other scans and reports that you may see are going to talk more about the shape of the fracture. You may see your typical, here we go, like a wedging type of fracture with decreased anterior of the body. There are going to be bowing of the superior and inferior surfaces. There may actually be gaps in the bone. So you'll hear it described different ways on the imaging reports. Rehabilitation is going to be similar for the different levels of vertebral fracture. The 2017 Journal of Orthopedic Trauma, they reviewed a bunch of different studies to try and look for trends in successful management. They didn't come up with one specific protocol, but what they did find is that unloading that anterior column is so important because that's where that body is and tends to have more compressive force that can't tolerate the loading. Spinal extension exercises are favored in order to decrease that anterior loading. And this is in addition to pain management modalities, medications, and we all know patient education is important, that bone safe mechanics. And we tell our patients, don't bend forward, don't, reach for things. Sometimes we need to be a little more prescriptive than that because they don't realize all the different instances this happens. Consider your patients and how are they dressing? How are they brushing their teeth? Are they leaning forward, leaning on the counter because they also have respiratory compromise from their lung pathology and now they have greater anterior loading? Are they sitting, getting dressed, unsupported on the edge of the bed where they're holding and moving their clothing, and now they have greater anterior loading, so they really shouldn't be doing upper extremity ADLs unless they're supported and extended as much as possible. We're going to maybe be more specific in our education of patients with that. Looking at bracing for individuals with vertebral compression fractures, the research does show that short-term bracing of about 6 to 8 weeks can help decrease pain and provide stability to those fracture sites as they heal. It'll decrease back muscle fatigue and allow for more comfort of the patient. A 2019 study looked at treadmill walking of patients with compression fractures and bracing, and they did find while they were in the bracing, they had a greater stride, more symmetry to their gait, a better cadence. Unfortunately, they did find that when they took that bracing away, over time, those effects were not carried over. We need to be mindful of that so that we add in exercises so that then the musculature can take over and habit can set in once healing has occurred. Surgical intervention may be necessary for some patients who present with compression fractures of the spine. Some individuals who have compression fractures, as we said, they didn't know they had it. And at some point in time, then it moves to a more persistent pain pattern. And where the pain comes from is the little bony fragments that haven't healed as they're shifting and moving against each other. That's what's creating the pain. In those instances, the physician would go in and stabilize those components. So they're going to go in with a vertebroplasty and inject bone cement just to try and stabilize those bony segments. They're not trying to restore alignment. When they go in and inject this on the right, we can see an image here. They're just trying to stabilize. They're not trying to increase the height or maintain alignment. It's really just an attempt at pain relief to allow for better function. If a fracture is recognized earlier, there might be that opportunity to do a kyphoplasty, where the goal would be to not only stabilize the segments, but to restore some height of that vertebral column so that we don't have as much compression on the nerves. And what they will do, if we look at the image on the far left here, I'll go inferior and superior. We can see the loss of height of this compression fracture. The physician went in, and in this area that I'm circling, they implant this little metal device that when they push it together, it expands out and it'll help raise up that vertebral body. And on the right-hand side here, we can see restored height of that vertebral body. And this physician also went in and did some pedicle stabilization for that individual. The concern becomes that when there is stabilization at one segment, does it increase the forces at the superior and inferior segments, placing them at a greater risk of fracture? The studies do show that the kyphoplasty has been beneficial in decreasing pain, increasing function through decreased disability scoring, but patients just need to be monitored for adjacent fractures. Spinal instrumented fusion would be indicated. Just because someone has osteoporosis doesn't mean they don't have other diagnoses. They may also present with spinal stenosis, spondylolisthesis, other pathologies where they're having excessive compression on the nerves that lead to other pathology. In that case, they may need surgery to realign that vertebral space, separate from any compression fractures they may have. When they look at trying to fixate into the bone, into those pedicles, the concern becomes, can they get those screws to hold on? Is there enough pull-out resistance to actually stabilize? I couldn't find any copyright-free human studies. This one is a canine study where they went in at the tip of my arrow here into the pedicles with coated screws that we've discussed. And when they scanned them, they actually find, when you look at the red, I'll outline it, the red is fibrous tissue. And that is going to be a screw that was not coated. And that fiber tissue doesn't have good bone integrity. It's not going to want to stay in there. When they used the bioactive screw, we saw significantly less formation of that fibrous tissue, so there was better bone quality, and it allowed for better stabilization. As we move down to the hip, looking at hip fractures that occur in individuals with osteoporosis, falls, stumbles, unusual, just losing their balance and maybe catching themselves against an object, or coughing and sneezing in the wrong position can lead to that hip fracture in addition to a fall. The physician is going to consider the level of the fracture and then the quality of the bone to decide if a total hip replacement should be done or if some type of stabilizing screws can be utilized. Oftentimes when our patients postoperatively have a total hip replacement or an ORIF, we might not know the mechanism of injury. And it's an important piece to consider, because if it is a fragility fracture, and it may not be written that way in the reports that we're able to obtain, our questioning may lead us to find, or looking at the past medical history to start putting the pieces together to see if we also need to add components to the rehab program, not only our balance, strengthening, mobility to recover from the surgical procedure, also components to address the osteoporosis for that patient. So we do want to know if it's a fragility fracture. The hope is to really recognize these fractures before they happen and help prevent them. So osteoporosis screening measures are utilized to try and identify individuals who are at risk. The two different components are bone mineral density testing, which is actually our diagnostic testing, and then we have clinical risk assessments, which are more data collection type of tools to see who is at risk before we put them through expensive testing to direct the right people down the appropriate path. The information that we're going to look at is from the United States Preventive Services Task Force, as well as the recommendations from the International Osteoporosis Foundation. The benefits of early detection are to find it early, to be able to step in sooner with interventions to help limit the progression of the osteoporosis and also decrease the risk of fractures, with our goal to reduce that morbidity and mortality for individuals. Bone mineral density screening is recognized for certain individuals, and the guidelines suggest that women who are over 65 and men who are over 70 should have bone mineral density testing. We know now, understanding the pathophysiology, that because of natural aging, greater risk of development of osteoporosis. Women who are under 65, if they have risk factors, they should also be screened. So not only risk factors of postmenopause, but any of the other risk factors, concurrent conditions that we've discussed. Same thing with males, 70 years old with risk factors should have the actual diagnostic screening. And then any adult who has a hip or vertebral fracture where it's not related to trauma, the thought there is that it's potentially a fragility fracture, and that needs to be ruled out by getting a diagnostic test to look at the actual quality of the bone. Screening intervals that should be utilized. The general recommendation is that 1 to 2 years after initial medical management. So if an individual is diagnosed with a certain level of osteoporosis or deterioration of their bone and there's medical intervention, a year or two later, there needs to be a reassessment to see if that intervention is successful, and then every 2 years after that. I was just curious as I was looking at the different studies to see if doing screening too early is potentially negative for patients. And what they found, which makes sense, is that there is no downside of screening for osteoporosis, that early detection is important to help treat it if it is present. But telling individuals they have deteriorating bone does not seem to have a negative effect on them. It's not like they shut down and tend to retract and decrease their quality of life and decrease their activities, which is not what we would want. So the research is supporting that there are positive benefits to this early detection. The main type, the gold standard, is going to be our DEXA scan. This is written as DEXA, dual energy X-ray absorptiometry, or DXA, you might see also. And then there's the development of some less expensive, more portable measures with ultrasound and CT scanning that we'll look at. The DEXA scanning is a low-level X-ray that is utilized. In order to explain it to individuals, they say the radiation exposure is less than that of a typical X-ray of your back, or if you were on a transatlantic flight, it's less X-ray exposure or radiation exposure than you would get just from being in the sky for that long from the sun in the sky. This test is specifically looking at the bony matrix. The mechanism through which it works is related to analysis of the calcium that's embedded in that bone matrix. Calcium tends to absorb radiation, so if it is absorbed on the scan, we'll see a solid bone mineral density. If there is a deterioration of the bone with less calcium, it'll show that on the scanning. Typically, what's utilized is a central scan using either the hip, the hip and the lumbar spine. This is because we're specifically looking at fractures in those regions, and they tend to be the areas that deteriorate most. For some individuals who have obesity or they are unable to utilize those central scanning, there are other methods of utilizing the radius and the calcaneus for peripheral scanning. But the values that we're going to discuss are related to the central scanning. That diagnostic criteria for bone mineral density values is measured in grams per centimeter square. What they look at is what normal bone integrity should be. What should the normal architecture look like for an individual who has their bone integrity at the peak of their life? And peak bone intensity tends to be at around 30 years old. So 30 years old is utilized as that reference for what's called our T-score. They're going to look at comparison of the individual's bone scan. So if I went for my bone scan, they're going to compare my bone density to an average female who's 30 years old. And they're going to look at how many standard deviations my density is away from that reference range. And they look at if 0 is that 30-year-old with peak bone density, then we're going to look at each standard deviation is about 10 to 12% better or worse than that reference range. So if someone is going into the negative, each standard deviation is 10 to 12% less than that reference range. Z-score is a little bit different. Z-score is going to compare individuals to age, sex, and ethnicity reference matched population. So you're compared to someone, where should a typical individual be at the point you are in life in terms of age and what gender and ethnicity you are. The reason the Z-scores are important is because if someone is premenopause, you want to compare them to someone at that same point in time, or particularly pediatric cases, or someone who has one of the other diagnoses that we talked about. It may be at a different point in their lifespan, so you need to look at them based on their age referenced, and that's where Z-scores are going to come in. Are they within the expected range, so they're above a -2, or are they below the expected range for like-matched comparison? What we're going to see more commonly, the World Health Organization classification is utilizing our T-scores. Our T-scores look at that comparison to an average 30-year-old with peak bone mineral density. So normal is you're less than one standard deviation away from that normal. So less than 10 to 12% away from that normal. Osteopenia is going to be a -1 to a -2.5. That means an individual in this range, their bone mineral density is somewhere in the range of 20 to 25% less than an average 30-year-old. That would be considered osteopenia. There's some weakening of the bone. Osteoporosis is going to be less than -2.5 T-score. And then established or severe osteoporosis is going to be that low T-score. So it's going to be -2.5 or more away from that 30-year-old. And they've already had at least one fracture. Quantitative ultrasound is a tool that is being utilized in some cases to look at more mass screening opportunities. It's less expensive, it's portable, and it uses the calcaneus. We might think, well, why are they looking at that calcaneus? And I found some interesting images. The far left here, we're looking at in this region that I'm circling. If you look at the integrity of the bone, it's someone who is 1906, is this one. And this is an individual who had syphilis with osteoporosis setting into their bone. And then this center image, if we look at that calcaneus deterioration on the scans, that is someone who was in a long leg cast for a fracture for 7 months without that weight-bearing force. We see that calcaneus tends to deteriorate rather quickly. So they're looking at scanning the calcaneus. They'll look at the transmission of the ultrasound waves through the bone and try to get a value to associate with the integrity of the bone. A formula from the machine calculates an equivalent T-score. So this is not utilized for the diagnosing criteria that we've discussed. There might be an opportunity in the future to use this as a less expensive and easier way to see who needs that DEXA scan. Same thing with the quantitative CT scan, looking at scanning either the spine or the hip to try and get a sense of osteoporosis that may be present. This area that tends to deteriorate most in the hip is Ward's triangle, the region in below the neck before the intertrochanteric region. We tend to see deterioration there, and then a thinning of the cortical bone in the adjacent areas. And the CT seems to be able to pick that up, but again, the values are from the machine, and the WHO equivalents are supposedly set up, but it's not a true diagnostic criteria, something that might be emerging in the future. Dental radiographs are a great opportunity to start looking earlier at individuals who may have that potential development of osteoporosis. Everyone goes and gets their teeth scanned when they do the large scans, and they look at this mandibular region and see how much it has deteriorated from that gum line going down. They're finding that there's some relationship between the bone density in the mandible as well as the change in the bone in the hip and the spine. They're considering this might be an early indicator for patients to see if there is potentially the development of osteoporosis starting. When we look at different blood tests and urine analysis to try and see objective measures related to osteoporosis, there are two different sets of values that are examined, looking at those related to bone formation, protein synthesis, as well as osteoblast activity to form that good solid bony matrix. We want to see high levels of those values. And then we want to see lower levels of those markers that are indicated of bone reabsorption. That if we see significant high levels of those enzymes that activate those osteoclasts to break down the bone, it might be concerning that the individual is presenting with osteoporosis. The lab values are trying to look at another indicator of that metabolism of the bone and the homeostasis that's occurring. And in the future, they're thinking it might provide more insight in a less invasive way and an earlier indicator of the development of osteoporosis for intervention to occur sooner before that sentinel event of a fracture. Clinical risk assessment tools are an opportunity to perform this on a wider scale and be more preventative in nature. They fall into two different categories. Number one, looking at that development of osteoporosis itself. What is the risk someone has that they may develop in the future or are already starting to develop osteoporosis? And then for other individuals, if they already have osteopenia or osteoporosis, what is their risk of fracture? And that may help direct if the individual needs more medication management and other interventions to try and decrease that risk of fracture and the negative sequela of events. All of the tools that we're going to discuss are from the 2018 U.S. Preventive Task Force recommendation statement, and they found that there's adequate evidence that these tools are moderately accurate, which is actually their positive recommendation. The International Osteoporosis Foundation Checklist. This is a quick little questionnaire that anyone can go online and do and would be easy to incorporate into our assessments. It's looking at different risk factors, BMI, is there height loss, other medical conditions, alcohol. So those indicators that we talked about that contribute in different ways to the pathogenesis of osteoporosis to see if there are multiple of them. One question might be on the survey, have you broken a bone after age 50? And that if that fracture happens to be one of the fragility fractures combined with other indicators could potentially indicate that the individual has or is at risk of osteoporosis. Another question that they ask is, since age 40, have you lost 1.5 inches of height? The simple calculated osteoporosis risk estimation, abbreviated, this is the SCORE test. It is not simple. It's actually a complex calculation, so the name is a little ironic, not to diminish its validity in any way. It's complex because it looks at all the different indicators, and it also pulls in estrogen levels, race, fracture history to try and come up with an osteoporosis score. They're again looking at specific locations of fractures. Has there been a rib, wrist, or hip fracture after age 45? That's not traumatic. When we look at the scores, if an individual has greater than a score of 6, so greater than 6 seems to be our threshold for individuals at moderate to high risk of developing osteoporosis or already having osteoporosis. This is actually the SCORE assessment has been found to have the highest sensitivity when they actually compare it with scanning and diagnostic imaging, and so it has a very high accuracy. The Osteoporosis Risk Assessment Instrument, the ORI, this again is a calculation. The score is a sum of different parameters, with the highest score on this being a 26. It is going to put the individual like in different age brackets where they'll get different points for the age bracket and similar indicators that we've already been looking at. The threshold for indicator of osteoporosis risk is greater than or equal to 9. And this again has a high sensitivity. However, its specificity, they say, is not as accurate, that it does pull some individuals who do not have low bone mineral density. The Osteoporosis Self-Assessment Tool, the OST, I'm going to date myself here. Hopefully there's one other person out there that can see this with me. We used to wear what's called pantyhose, stockings that are rarely worn now. And the way you would find your size is you'd look at your height and you'd look at your weight and you would land on the chart and say, oh, that's my size. This tool works similar. It's looking at body weight, and body weight is going to be a low at the top here. And then when we look at age, age is getting older as we go to the right. And if you look at that, we said low body weight and higher age, those are going to be our higher scores, more negative score, which is indicative of a greater risk of osteoporosis. And those would indicate individuals who would need screening for osteoporosis. Moderate risk is from 1 to 3 in this region, and then high risk is going to be all up in this region. So older and less weight. It's interesting, this was first developed for individuals who are Asian and has been adapted for other individuals. The last one is the Male Osteoporosis Risk Estimation Score, the MORS. This was developed by looking at the Haynes data, and they developed it in reverse. They already knew from the national data who developed osteoporosis, and they pulled all the different indicators to keep trying to figure out a score that would land on those individuals in the future to hopefully catch them sooner. And they first thought in men that cigarette smoking was a big indicator, but when they calculated the math, it didn't work. It's actually COPD history combined with age and weight seem to be big indicators. And our threshold score here is 6. And we said that often it's misdiagnosed or undiagnosed in males, and they have greater mortality. This might be an assessment for us to consider adding to our toolbox. Those different diagnostic assessments that include actual imaging scans, we have different tools that we can look at to determine if a patient coming in is at risk for osteoporosis, to direct our management, as well as look for outside referrals. And then the third component is fracture risk assessment. The concern that we have that individual may sustain a fracture of that bone that's already weak and can't be resistant to external forces. When we look at this individual ambulating on the left here, just examining, we assume that there are several risk factors or concerns for osteoporosis. We see significant kyphotic posture. We see the forward head. This is creating a lot of anterior loading. Looking at the gait, there is mid stance on the right and almost done with toe off on the left. The bag here, placing excess force for uneven balance. And all of this, when we look at it, we have a concern, not only what caused it related to either primary or secondary osteoporosis, but we see a significant fall risk concern just from a mobility perspective for this individual. And we need to globally assess all the different risk factors for falling. Specific to individuals who have osteoporosis, the fracture risk assessment tool is what will provide the most information, specifically looking at that next 10-year block of time and their probability of fractures in the next 10 years to help direct the appropriate interventions to minimize that risk. This tool was developed by the WHO in collaboration with the Center for Metabolic Bone Disease, and it was launched by the University of Sheffield in England. It has since been incorporated into use to be a good prognostic indicator of that fracture risk to help direct medical interventions. The way the tool works is takes data from the DEXA scan, so looking at is there osteopenia, osteoporosis, or severe osteoporosis. It'll add in those different physical traits, those non-modifiable risk factors, age, gender, height, and weight, and then looking at history or other contributors to the pathogenesis, lifestyle factors. Have there already been a fracture? To put all this information together to come up with a calculation of that specific risk of fracture. It's going to, when you go in to utilize the tool online, the individual is going to select their country. It looks at ethnicity, and it's pulling together all of this different information to help predict spine, forearm, hip fracture risk. Management for the individual with osteoporosis is then going to be multimodal, pulling in all of the different aspects to manage if there is an underlying disease and manage the osteoporosis itself through pharmacologic treatments, diet, and supplements. From a rehab perspective, we're looking at fall prevention and exercise to be osteogenic, as well as for general strengthening and conditioning, and to manage any of those underlying disease conditions also. And then fracture liaison services are a resource to help fill any of the other gaps. So the whole team is working together in order to slow the progression of the osteoporosis and help prevent fractures to maintain quality of life and longevity. Pharmacologic treatment thresholds have been established. Some patients may need more than just lifestyle and exercise management for their osteoporosis. The National Osteoporosis Foundation recommends that individuals who do have that asymptomatic fracture, that a fragility fracture that occurred that they didn't realize about, those with less than a negative 2.5 T-score, those are our individuals who have diagnosed osteoporosis and already were seeing that decreased integrity. And then also for individuals who are postmenopausal women and men who are over 50, if their T-scores have already diminished to the point of osteopenia, and if they have that FRAX score of greater than 20%, that the likelihood of them having fracture in the next 10 years is more than 20%, that would also put them in a category where some type of medical management is going to be necessary with medications. The FDA has two main categories of approved medications to manage osteoporosis. They have different molecular and cellular targets to exert their action that will target different causes or components of this process that leads to osteoporosis and the demineralization of the bone. The goal is to help the bone better be able to withstand the different forces placed upon it. First category are our anti-reabsorptive agents. These are going to target our osteoclasts in order to limit the turnover of the bone to stop that breakdown of the bone itself. Those will be our estrogen, bisphosphonates, rankle inhibitors, and SERMs. Then we have our anabolic types of medications. The focus of these medications are going to be the osteoblasts in order to stimulate that bone formation. They're trying to increase mineralization, increase bone mass, and that's going to be targeting that parathyroid pathway. We'll look at each specifically. When a patient's on medications, we need to understand the mechanism of action of the medication, what should it be accomplishing, and then we also need to recognize the potential adverse events so that we can recognize them early if they're present and make the appropriate referrals and see if there's anything to do to help minimize them in their development. Our first anti-reabsorbed agent and the most common is the bisphosphonates. For all the medications, I've included the generic names. We know that the marketed names change over time. To give you an idea, some of the marketing names or current brands for the bisphosphonates are Fosamax, Boniva, Reclast. The mechanism of action for these medications are inhibitory. They're going to be oral or injectable, and their focus is to bind in that trabecular matrix within that scaffolding. The osteoclasts are going to absorb the components of this medication, and when the osteoclasts absorb them, the binding sites are changed and they can't actually adhere onto the bone to start breaking it down. So because the osteoclast can't do its activity to break down the bone, which is what we want because we want it to be protective, that osteoclast is going to undergo apoptosis, which means cell death. So those osteoclasts die and are not functional, and now the reabsorption is suppressed, bone integrity should start to improve for that individual. Remember in the beginning we looked at those circular matrix and where those different osteoclasts and osteoblasts are located? And those osteoclasts are actually embedded in that cross-section of that trabecular matrix. Because they're embedded in there and they've absorbed this medication, they actually become part of the bony matrix. When an individual stops taking the oral medication, those osteoclasts that over the previous several years have been absorbing it are still present in the bony matrix and are still being inhibited from breaking down the bone. And what they're finding And the current recommendation is that patients on bisphosphonates, they need to take a holiday from it because of the significant adverse effects that can occur. By taking that holiday, the research says that they still have 3 to 5 years of protective benefits from this medication because it's now become part of the matrix, and the FDA recommends that holiday to help decrease some of these potential adverse effects. The specific ones that we're going to look at are jaw necrosis and atypical femur fracture. We're all familiar with how to monitor patients for DVT, as well as they should be undergoing screening for their kidney functioning if they're taking these medications. Medication-related osteonecrosis of the jaw, it's a relatively new terminology. It seems to occur in a percentage of patients who are on bisphosphonates. It's not well defined in the research. They're still trying to work out the details, which I think is a good opportunity for us to be aware and educate our patients to hopefully avoid it. What they're finding in individuals who are on the bisphosphonates, remember we said that they're finding that when they look at the mandible, there's some correlation to the alterations in bone density in the mandible compared to the spine and the femur, indicating osteoporosis. It makes sense then that the same medications that are inhibiting the osteoclasts in those other areas are doing the same thing in the jaw. And what they're finding that anti-reabsorptive medication is impacting the mandible and the jaw also. And then when the patient undergoes a dental implant or some type of extraction, they have cancer, maxillofacial, poor oral hygiene. Those are triggers then that lead to the development of an infection that does not heal and can lead to osteonecrosis. It is important then to recognize that patients who are on bisphosphonates, they need to check with their medical doctor before they go in for any oral type of procedures, and they need to let their oral surgeon and dentist know, even when they go for their cleaning, that they're on those bisphosphonates, to be aware. Atypical femur fracture is an adverse effect that can occur again from these bisphosphonate medications that are functioning to try and improve bone integrity. May not make sense. Stick with me. When we look at atypical femur fractures, it's somewhere occurring for the individual. It's going to be below the trochanter and above the supracondylar line. So it's somewhere in the long part of the bone. The individual is going to sustain either a clean, straight through femur fracture. They tend to be more oblique in nature. They're not comminuted. On scans, we can see here, it's almost like a little splintering of the femur. And again, the mechanism they haven't totally figured out, but what they're finding is long-term use of the bisphosphonates somehow is going to alter the long bony matrix or the cortical component of the bone in a way that it makes it more prone to fracture without any sustained force. Now, our osteoporotic fragility fractures, they're going to be up higher in the femur. So this is along the shaft. They find that the patients tend to have a prodrome leading to this, where in the months leading up to the fracture, they start to have kind of like a dull, aching discomfort. For many of the patients, there's no significant mechanism of injury. It's a low load type of injury where they may not even realize it happens. Important for us to know if we're doing exercise programs for patients with osteoporosis, if they start to present with this, it could potentially be that complication, and now they have that fracture that has to be addressed. The next type of medications are our receptor activator of nuclear factor kappa B ligand. Woof. Those are our RANKL inhibitors. This is going to be an injection that the individual receives about every 6 months. It's a monoclonal antibody that is considered a bone density conservation agent. It's working to preserve the bone. What happens is it's going to bind to RANKL, and RANKL is going to be kind of like a switch that functions in order to signal the osteoclasts to break down the bone. So the RANKL should come tell the osteoclast to start breaking down the bone. What happens is this medication comes in and it binds to that RANKL so that it can't attach on to the osteoclast. So the osteoclast never actually matures and is able to execute its function of breaking down the bone. The survival of the osteoclast is going to be limited, and then in that respect, it ends up preserving the bone mass for the individual. They're finding, again, the osteonecrosis of the jaw is a risk factor. One of the brand names for this is Prolia. Another complication we have to monitor patients for, particularly with the RANKL inhibitors, is hypocalcemia, low calcium in the blood. For some reason, this tends to occur more with the RANKLs. If someone has another condition, gastrointestinal, for example, where they're not getting enough calcium into their bloodstream, that pathway of the parathyroid hormone wants to go grab it from the bone. If they're on a RANKL inhibitor to protect from the osteoporosis, it can't go grab from the bone. Well, now we have low calcium in the circulatory system, and now we can see other symptoms occurring. The individual might start to present with more muscle cramps, muscle spasms, numbness and tingling of the fingers if the nerves are involved. Monitor for those things. Also, the individuals tend to be at a greater risk of infections and skin rashes, particularly if they're on other immunosuppressive agents for their other diagnoses. They might have a urinary tract infection, so they have burning with urination. Monitor them for cellulitis. Just be aware of these potential adverse effects. Selective estrogen receptor modulators are SERMs. The brand name that you might hear currently is Avista. This is a daily orally administered medication. It's only utilized in postmenopausal women because the goal of this medication is to simulate the role of estrogen. And the role of estrogen, it is going to be an agonist for the bone because it's going to shut off those osteoclasts. So by shutting off those osteoclasts, like estrogen would have done, it's going to protect the bone. They're also finding that in women who are at an increased risk of breast cancer, that the SERMs are going to bind to the receptors on the breast cells, and they tend to have more of a protective effect against breast cancer. The physician may pick this for someone who is at a greater risk of breast cancer. Side effects that we're looking for are blood clots. Our concerns would be DVT, transient ischemic attacks. If someone also has coronary artery disease because of the lower estrogen levels, we're going to monitor more closely. The other category of medications are looking at building back up the bone. Many of these are going to focus on that parathyroid hormone. Fortis, Thymos are some of the brand names that you might hear. These are synthetic forms of the parathyroid hormone that the individual receives. And usually we know that parathyroid hormone is going to function to maintain the calcium homeostasis in the blood. What these synthetic forms do is they tend to enhance the functioning of the osteoblasts, and they're going to allow them to be more effective at depositing the calcium that's present into that trabecular bony matrix, as well as it seems to strengthen the cortical bone that is being formed for the patient. The concern with this, it has a black box warning from the FDA, and those are the most significant warnings that the FDA does provide. They haven't really found it in human models, but in the animal studies, what they're finding is that there is an increased risk of the development of osteosarcoma. Mechanism of action has not been figured out yet. They just know that it seems to be associated with this medication, so patients do have to be monitored more closely. Sclerostin inhibitors, brand name is Invinity. This type of medication was recently approved in 2019. It's an antibody from the Chinese hamster ovary. How someone thought to do that, I don't know, but nice that they did. So now we have this medication available. The research is demonstrating that this particular medication helps to build up the bone mineral density in a couple of different ways. That it tends to have, in individuals who take it, they see higher pro-collagen biomarkers, and they are looking at blocking the protein that turns off the osteoblasts, so it allows them to work longer and better to build up the bone, and then at the same time it's going to slow down those osteoclasts. So it's indicating that it really provides that specific mechanism to help build up the bone integrity. Another black box warning from the FDA with this medication: if the individual in the past 12 months has had a myocardial infarction, stroke, or cardiovascular event, they are not a good candidate for this medication because they tend to see increased complications in those areas. In addition to atypical femur fracture, jaw necrosis, and hypocalcemia. This medication does seem to pull in a lot of the adverse effects from all the other medications that we have discussed. So it might have you wondering who's even going to take it. At this time, it seems to be indicated for women who cannot take other medications or where other medications just have not been effective for them, and that osteoporosis really needs to be managed. The way that this is delivered, it's in a 2-injection series that the individual has once a month for a course of a year of treatment. And because of that concern of the complications, they would take a break from it. But hopefully in that time, it had beneficial effects for them. Overall, looking at these medications, when we look at the drug therapy outcomes, for postmenopausal women, looking at the different studies that are out there, from 2018, the U.S. Preventive Task Force pulled all the different research, and they didn't find a lot of research studies that met their stringent criteria for quality. Of those that they did find, they found 14 studies on the bisphosphonates that they did help reduce vertebral and non-vertebral fractures, but not the hip. So other non-vertebral fractures would be radius, maybe a rib fracture. The SERMs, rankles, and parathyroid hormone do seem to help vertebral fractures also, but not as much for non-vertebral. This, I think, the fact that the medications for patients who are at that level where medication is indicated, we know that their osteoporosis is more progressed or they're at a greater risk because of other comorbidities and factors. This, I think, gives us a nice highlight to say that we need to include education and exercise programs that do address the hip and the upper extremity that are also at risk for osteoporotic fractures with our patient education and exercise. Looking at the outcomes for men, there was one study that they found that was able to provide some information that the bisphosphonates did help with vertebral fractures. Research continues to be lacking in men, and that's one of the pushes to not only identify this population, but get more data on good ways to help manage them. Dietary modifications are another opportunity to help manage osteoporosis. The International Osteoporosis Foundation actually has an app that you can download to monitor the calcium intake to assess and track it. The recommendation increases with age how much calcium someone needs in their diet. And for women who are over 51, any woman who is postmenopausal, and men over 70, the recommendation is 1,200 milligrams a day. Even if they're taking medications to help be anti-reabsorb or to be anabolic to help build up that bone, they still need the calcium present in their diet. So there still needs to be a component, and vitamin D needs to be there also to remodel that bone. So it'll be combined with nutritional counseling to help gradually raise their level. Different sources of calcium in the diet. The first thing that comes to mind is milk, and I thought it was interesting to see that there is still 300 milligrams in 8 ounces of milk, whether it is skim, whole milk, 2%, so we can still be heart healthy and get our calcium. Broccoli, interestingly enough, in 8 ounces has 60 milligrams of calcium. Other foods, bok choy, kale, apricots, oranges, different nuts, yogurt. For someone who maybe they have celiac disease or they're lactose intolerant, so they're on a different modified diet, there are fortified foods, orange juice, almond milk, soy milk, that have the same amount of calcium in them as regular milk, that same 300 milligrams for 8 ounces. Even tofu, there's the calcium set tofu that is available. And I thought it was interesting as I was trying to plan my diet, because sardines are not at the top of my list, that yogurt has 250 milligrams in a serving, but ricotta cheese has 335. And you got to look at the fat component there as well as protein. But there are some different alternatives as individuals look into the dietary opportunities. Vitamin D has to be bioavailable. So just getting it in is not the only piece. It has to be at a sufficient level in the circulatory system, and most individuals do not get it from the sunlight, particularly in the winter months in the northern hemisphere, but also in the south here, we're constantly wearing sunblock. We're covering, we have tints on all of our windows. So food sources are often relied upon. The general recommendation, there are different ways that this is measured, so I encourage you to look at this if you're looking at lab values, that we're looking at somewhere for our sufficient levels is going to be somewhere between 20 and 50. We don't want to go over 50 nanograms per milliliter of bioavailability of the vitamin D. Vitamin D intake recommendations are 80 to 100 IUs a day. At what age to start that really varies by the recommending organization, somewhere between 50 and 70 years old. The recommended daily dietary allowance to achieve those serum levels varies. And remember that individuals who have osteoporosis may need these higher levels. To actually prevent fracture, some of the research says they need up to 2,000 IUs a day to really be protective from the fracture piece of it. How we're getting our vitamin D in our diet. Sun is the best opportunity, that 15 to 30 minutes a day of sufficient sun exposure without sunscreen on. Animal sources such as salmon, eggs, liver are a good source of vitamin D3. D2 is an opportunity through different plant sources as well as fortified foods. Interesting, mushrooms came up as an opportunity. Mushrooms are exposed to a lot of UV lights. They have a lot of vitamin D. We have our fortified milk that's available, as well as cereals and other opportunities to get that in our diet. For fracture prevention, as I mentioned, the recommendations are varying. They're still trying to figure out how much vitamin D specifically for fracture prevention. The one study that I could find said that in postmenopausal women, less than 400 IUs has no benefit. They know that, but there's insufficient evidence that greater than that is protective. So they're still trying to figure out those recommendations specifically for fracture prevention. The concern with supplements and taking too much is that if a patient or an individual is taking vitamin D and calcium, that they are increasing their levels too much. That can lead to stones, renal calculi. The suggestion is that dietary intake is slowly going to increase the levels. That tends to be the preference. When it's an orally administered supplement, the risk of toxicity is greater. So this is something that for the patient, the physician to have a conversation about and to monitor their levels to see the best opportunity. Fall risk assessment is moving into our therapeutic aspect, where we are looking at being osteogenic to help build and maintain bone. And then we really want to be thinking about decreasing the risk of fracture. And one of the biggest contributors to fracture is fall. We're going to look at visual and cognitive impairment that may be contributing to balance and fall risk, as well as balance and gait deficits, and if there are any side effects from different medications that the individual may be on. Are they getting dizzy? Are they too tired and sleepy so they're losing their balance? There may be sedative effects of different medications. And again, for that visual impairment, are they going for their annual eye exams? Do they have macular degeneration that has developed? Might they also have diabetes that affects that microvasculature and they have vision changes, and they're also at that greater risk of osteoporosis, and because their kidneys are not functioning well, they're more fatigued, and they have multiple aspects we need to address. Orthostatic or postural hypotension is something we want to assess our patients for to see if they are getting dizzy when they first get up. We want to try and limit those falls for them. It may predispose them. So you're going to have your patient lie supine for 5 minutes, check blood pressure and pulse rate, have them stand, get that immediate measure, follow them after 3 minutes. If that systolic drops greater than 20 millimeters of mercury or the diastolic drops greater than 10 and/or, and that individual may be presenting with postural hypotension that's associated with that vertigo and that dizziness, those abdominal responses we do need to follow up with the physician on. Other fall risk assessment tools that we might be looking at, and I tried to couch this from the perspective of envisioning the patient we're talking about who presents with osteoporosis. Our TUG test we use for many different populations where the patient stands, they walk the 3 meters, they turn around, and they come back. We know the test. Looking at it with an eye for a patient who's at fall risk and we're thinking about osteoporosis, we want to look at the quality of their movement and how are they particularly doing that turn. Are they doing end block turning where the head, the shoulders, the pelvis, everything's turning together and it's at a slow rate? Or are they able to dissociate because that'll allow for better balance? And look at the stride, look at the step length, is their arm swing? So you can throw in your gait analysis to hone in on what might be decreasing that balance. The 30-second chair stand test, individuals going to cross their arms. We're going to have them in 30 seconds. We'll count how many times they are able to stand up without using their hands. Individuals, this particularly is looking at that leg strength component for sit to stands, the endurance of the lower extremity musculature. The number varies by age of how many should be performed. To give you an idea, the average 70-year-old should be able to perform 11 if they're a male, and if they are female, they should be able to perform 10. So every time I prepare for this, I go and I test myself, make sure I'm still good for my age. The 4-stage balance test, many of you may be doing this already, you just might not be giving it the formal name. This particular assessment is looking at progressively challenging that base of support for balance. So the individual is going to start with the feet together with that narrow base, see if they can hold it 10 seconds, go to the toes of one foot in the instep of the other, progressing to tandem, and then single limb to see if they can hold each of those for the 10 seconds. Generally speaking, the risk of fall is identified in individuals who are unable to hold that tandem for at least 10 seconds. Our fall prevention components are going to be implemented once we've identified it. A big push is to decrease that potential of falling to avoid hopefully those negative consequences of that potential fracture. Looking at this woman who clearly has a significant kyphosis, my concern here would be the height that she has of this bowl as she's washing her dishes in, how far away her arms are with the weight of that plate. There's a lot of anterior loading. Just look at the clutter in that area. That just concerns me in terms of her reaching for things or being able to put something down safe or have a surface to lean or rest on, and then extrapolate that out to what does the rest of the house look like in terms of safety for that individual. It's a monochromatic scheme. Is there enough contrast between surfaces if she has any visual impairment to see the different surfaces? So home modification may be a component. The Check Your Risk for Falling is an assessment tool that is part of the CDC's STEADY program. It is Stopping Elderly Accidents, Deaths, Injuries program, and there are resources available online. I have the links at the end of the course notes packet. And it just provides another resource to start that conversation with the patient that may be sometimes challenging about home modifications. The U.S. Preventive Task Force does say that there is moderate evidence that strength and balancing program and exercise can help decrease the risk of falling. So visual impairment adaptations to incorporate related to falling is think about color schemes for impairment. Maybe somebody thinks a blue chair on a green carpet looks good, but visual depth perception, that will be hard to see. Some easy modifications to allow that person to better see their target to help decrease that risk of falling or missing the seat or bumping into it. Maybe they lay a different colored contrasting towel across the back or put something on the seat so that they can see it. And it doesn't mean big changes to their home. Look at these stairs in the center image. How is someone going to see where to put their foot on that step? So they make all different colored now, inexpensive tape, duct tape that you can use. Put a contrasting color along the edge. Put a contrasting color along the edge of the counter, around the doorway, over a threshold. It's great on the right. This person has a grab bar here. Some of you may not have even seen it because it's the same color as the other surface. Things should really be contrasting so that an individual can see it. There are simple modifications we can do. It's not just lighting in order to help create an environment that is more friendly to decrease the risk of falling. For individuals who present with that constitutional thinness, where they just might not have a lot of protective padding on their own body, there are hip protectors that can be worn that have the padding built into the undergarments, or they go over the individual's own garments. That are worn that if they do bump into something or they have a loss of balance where they steady themselves or a fall to the ground where maybe there's a little more padding to try and prevent that hip fracture. There was a 2020 study that looked at the use of hip protectors on over 600 ambulatory elderly females in several different nursing homes, and they did find that this was effective for those with low BMI in decreasing the consequences of falls in terms of fracture. The activating spinal orthosis might be utilized in some individuals to help encourage that postural alignment with extension to decrease that anterior loading on the anterior vertebral bodies. The way that this works is it's kind of put on like a backpack. It has the rigid component along the spine, and then it has straps that come along the waist and over the shoulders. The way that it works is as the person either bends forward or slumps forward because it's rigid in the back, it pulls on these straps and is going to give them a cue to activate their trunk extensors. So it's not doing the job for them. It's encouraging them to utilize their own musculature in order to help strengthen it. It's a more dynamic tool. They have found that individuals who are utilizing it show improved posture. They're recognizing decreased pain from those osteoporotic compression fractures, increased respiratory capacity. The research is still evolving on how best to utilize this and incorporate it into programs. Bone-safe body mechanics are something we're going to incorporate for our patients. We know avoid slouching, avoid leaning forward, avoid twisting. Does the patient necessarily realize, whether they're adult or pediatric, we said this is a broad age range and functional abilities. Do they know that holding a puppy or anything out like this is a long lever arm anterior load that could put too much compressive force across that spine? The individual, instead of carrying that heavy pocketbook on their arm or in their hand or even on their shoulder that creates asymmetry and loading, maybe a fanny pack, and they make them much nicer now. I don't even think they're called that anymore. I don't know what they call them. But using that might be a better option. How are they unloading the dryer, unloading the dishwasher? Sleeping position. We want to make sure on the bottom right here there's a pillow between the knees, the head is supported, the trunk is aligned. When someone's going up the stairs, they should utilize the rail, but if they're reaching really far forward and pulling, we're creating that anterior excessive loading, so it might not be as protective as we think. And don't forget to educate patients when they're coughing or sneezing. They don't want to flex forward. They should either put one arm behind their back, or they should flex their knees a little and put one hand on their opposite thigh to try, and they're not kyphosis forward, they're just kind of hinging at the pelvis to give a little bit of support. And that's trying to protect that vertebral column from the forces. As we look at different exercise recommendations, the general recommendations is 30 minutes of weight bearing, most days a week, combined with muscle strengthening, balance, and other functional activities in order to help and be osteogenic. Specific exercise prescription considerations. There was a 2019 report in the Brazilian Journal of Physical Therapy. It did a really nice job in clearly explaining all the different considerations for patients with osteoporosis. And I'm a firm believer that, yes, protocols are necessary in some instances. However, for this population, understanding everything we've talked about up to this point and recognizing the key components of exercise allows us to develop patient-specific interventions that can be effective. One consideration that we're looking at is that forces on the bone should be dynamic, not static, in order to encourage bone development. That they need to be changing the magnitude and the force that's across it, and the bones, that force that goes across it, it doesn't have to be huge. It just needs to be more than what is typical for that person. So if you have someone at a wheelchair, more sedentary level, maybe standing up doing some squats is enough for them. Someone who is at a higher level, they're younger, they're more fit, they may need to be doing more hopping and jumping and other activities. It just needs to be more than what's typical for them so that the bone continues to adjust and adapt. It needs to be in diverse directions. Everything does not need to be a longitudinal compressive high force. Just the pull of our muscles on our bones, upper and lower and trunk from different directions, are going to stimulate bone remodeling. We're also looking at that there should be different cycles, so it should be loading and unloading of the bone. Aerobic training for individuals to be preventative for osteoporosis or to have a benefit on the bone really is not happening. They're not bone stimulating type of activities, running, cycling, swimming. However, they are good for general cardiometabolic functioning that may help address other causes of secondary osteoporosis or for general health and well-being, but it needs to have other components added to it to be more osteogenic in nature. So someone who does like walking, maybe they need to be doing some curbs in between or incorporate some steps along their walk or be doing something else. Dancing instead of just walking to alter the forces a little bit more across that bone. When we look at different weight-bearing exercises, again, we don't need to have the picture in our head that the person needs to be doing burpees all day in order to be osteogenic. We need to balance the weight-bearing exercise to stimulate the bone with preventing fracture and not creating a situation where the person loses their balance, falls, and has an upper or lower extremity or a spine fracture. Looking at some research that was pulled in order to see the amount of ground reaction force that's coming up through the bone with different activities, what's generally suggested in order to be osteogenic in nature to help improve bone strength is that we want to have greater than 2 times the body weight going through the bone. So that ground reaction force coming up should be greater than two times the body weight. And if we look at this chart, a lunge is about 1 times the body weight. But if this individual is holding weights as they lunge, that increases it. And a lunge can be done, right? It doesn't need to be this deep. We can have that be less. Lateral step-ups are 2.1 times the body weight, but just on a low step. Just increase that lateral step up to a higher step. It's 3 times the body weight. So instead of just doing forward, do some lateral. Hopping and jumping, we know, are going to be higher, but the even just dancing, that dancing can be almost 3 times the body weight. Performing a foot stomp, where someone, instead of just walking, if they, marching in places, all they can do, maybe they can gently stomp a little bit. That's going to be over 4 times the body weight. So there are different ways that we can incorporate many different weight bearing activities in order to stimulate that bone and still be safe for that patient. Progressive resistance training is going to put force across the bones in different directions in order to help strengthen it. So we do want to have some general resistance training, not just to help with balance and stability, but it can help stimulate the bone. They're finding that as muscle atrophies with age, we lose more of our type 2 fibers, which are our power muscle fibers. They're also finding in individuals with osteoporosis, those particular muscle fibers are more prone to atrophy. So another reason that resistance training can also be helpful for individuals with osteoporosis. The general recommendation is to increase the intensity slowly. Maybe start at 50% of one repetition max. Do high reps, 15, 20. Then when the individual's ready to progress in a couple of weeks, increase the percentage and decrease those repetitions, and then slowly build with that. We're looking at, these can be basic exercises. Yes, squats and lunges, but also, rows, hip, ab, and adduction, tricep work. Balance and mobility training is an important component to help allow for not only different pulls of muscle forces on the bones, but also to encourage balance, alter base of support. We think of yoga, different types of activities to optimize muscle function, increase balance to decrease that risk of falls. Also consider, patient may not be able to do yoga positions. Maybe they're just at an ambulatory level and you want to keep it safe for fall prevention. Have them walk with doing more pivots, walk doing figure eights around an obstacle course. That's a different kind of balance training. And don't forget dual task training. This is important for so many of our patient populations. How often are we ever just walking? Concentrating on the walking, nothing else, no distractions in a tunnel. Patients need to be able to cognitively function while they're experiencing muscle endurance challenges and fatigue. We should incorporate that into our training. As we're doing gait training with patients, have them count backwards, name different animals, hold a glass of water and not be able to spill it. We need to incorporate dual task training also. There are several specific programs that have been developed that are supervised exercise programs. The Otago program was developed in New Zealand. It has been endorsed by the CDC in 2018, and this is a supervised exercise program initially, where the patient comes in, they're instructed in general lower extremity exercises. Is about a 30-minute exercise program. Long arc quads, short arc quads, hamstring curls. It includes a walking program, chin tucks, trunk extension, some weight bearing exercises. The link is in the course notes packet. And then the therapist follows up with the patient at 6 months, 9 months, and 12 months to see how they're doing with their plan. And the research is showing that individuals who participate in this specific program, that they have a significant reduction in their risk of falls that are associated with exercise programs, specifically where the individual has over 50 hours invested in the exercise program. That when they're challenged to that level, it's when it seems to have the most benefit. The Tai Chi Chuan program It is Moving for Better Balance. This is from the early 2000s. It was developed out in Oregon Research Institute. The program is now promoted by the CDC and the National Council on Aging. It's not specific for osteoporosis, though the research does show that it is helpful in decreasing falls. It's several different movement patterns that focus on weight bearing, rooting that stance leg, and then slowly shifting the weight and moving the core in order to create stability and balance. They're simple, continuous movement patterns that are really focusing on symmetry, coordination, but they also pull in balance and range of motion. Focuses a lot on eye and head movements to really incorporate all the different systems in order to help with balance. And it's a weekly program that classes that individuals would go through. Whole body vibration therapy. This was originally developed for astronauts in order to try and maintain their bone integrity. And I have to say, I've really enjoyed watching on the International Space Station the different exercise equipment that they're utilizing to be able to do resistance training and weight-bearing exercises while they're in an anti-gravity situation. Specifically, whole body vibration is a platform that the individual stands on, and it's going to transmit those vibrations up through the bone. There was a 2016 systematic review that I found. It looked at 12 different studies that had analyzed this. They did find that it improved bone mineral density. They found improvement in those biomarkers to be positive for bone integrity. Mechanism of action is where they're really not sure yet. Then it might be associated with changing the vasculature in the bone to allow it to mineralize better. They're really not sure. It's still considered investigational at this point. One study I read said they're unclear. It's uncertainty, it's investigational, and it's not a substitute for therapeutic and pharmacologic management. Might be something that maybe we'll see in the future, though. Overall, looking at the exercise outcomes of some of these different programs beyond our typical, what they're finding is 6 weeks participation in resistance training and using an orthosis did help improve the tug scores as well as training for individuals, strength that then should correlate into decreased risk of falls. In our female populations, after 6 months of training, they found that there was decreased pain and increased strength, but it did not actually change the spinal curve. These individuals had participated in ball work and exercise programs, treadmill walking. Fracture liaison services are the opportunity to fill the gaps and help coordinate everything that we've discussed, because you might be thinking now, great, I want to hit on all these different aspects, might all not fall within the scope of the referral that you're receiving. So fracture liaison services might be available through insurance. They're also available through the American Orthopedic Association, the International Osteoporosis Foundation, where there are newsletters, resources, tools available. But there's also counseling and an opportunity to help coordinate care for individuals to help with not only fracture prevention, but guidance on identifying and treating osteoporosis. It might be an opportunity for us to help coordinate all the different aspects of care for the individual. Throughout this course, we've taken time to look at all the different populations who are at risk for the development of osteoporosis and how that actually develops so that we can understand pharmacologic management and complications that we will educate and monitor our patients about, and also so that we understand how bone integrity is compromised with osteoporosis and how exercise can target the bone in order to help increase in its quality, decrease risk of falls for our patients to improve their quality of life.
Do you know what the subsequent amount of decreased absorption is when caring for someone with gastric bypass? I think you're referring to the vitamin D absorption. Individuals who have undergone gastric bypass surgery may have a higher incidence of osteoporosis and therefore require a higher degree of surveillance of their bone mineral density. That would be in the years following their surgery and then continuing through their life. I don't know the specific timeline of potential bone compromise. It would be a beneficial conversation to have with the patient's physician to guide long term planning. Our exercise programs, when we're rehabbing these patients, should be osteogenic in nature, looking ahead to that potential development of osteoporosis. As you identify trends in the patients that you're treating and you continue to read future research that is published, there's more investigation into the development of osteoporosis following bariatric surgeries for weight management. It's important to know which type of procedure the patient has, and when you look at the research studies, so that you can apply the information. The Roux-en-Y gastric bypass procedure is a type of weight loss surgery. It involves creating that small pouch from the stomach and then connecting that pouch directly to the small intestine. So that is bypassing that upper small intestine area where vitamin D is typically going to be absorbed. So, because the vitamin D is not passing through that area because of the bypass surgery, it doesn't become bioavailable for the patient through their dietary intake. The physician needs to determine then what increased supplementation might be necessary for the patient to ensure that they do have that vitamin D bioavailable for management of that bony architecture. Researchers in the United States published a study in late 2021 looking at this association of patients with osteoporosis following a gastric bypass surgery. It was a multi-center retrospective analysis. The RYGB procedure that I just described, it was associated with a greater reduction in bone mineral density. They also found that vitamin D deficiency was more common in individuals following that procedure. And then they also found on the biomarkers for burn turnover that there was a greater increase of those, all fitting with the development of that osteoporosis. All of that together then puts that patient at a greater risk of fracture development because of the weakness of the bones. When they looked at the individuals who went through that bypass surgery compared to those who had the sleeve gastrectomy procedure done, they noticed a difference in the development of osteoporosis. Those with the sleeve had less development of the osteoporosis, less changes in the biomarkers, less vitamin D deficiency. At 3 years post surgery, both procedures did find some complications. It's just that those with the sleeve procedure were less likely to have them. Either way, this gives some indication that the effects of that vitamin D deficiency may begin within a few years, prompting consideration of osteogenic exercise as part of our rehabilitation program, and then also our discharge planning for any of our post-operative bariatric surgery patients. What is the difference between the T and Z scores? Both are utilized to classify bone density that's analyzed through DEXA scanning. T scores are the standard to diagnose primary osteoporosis, comparing the individual's bone integrity to that of a healthy 30-year-old. Those are utilized as a T score because postmenopausal osteoporosis, the senile age related osteoporosis is looking at how the bone changes over the lifetime. And they want to know, compared to that optimal bone integrity of a 30-year-old, how well is that individual's bone holding up in terms of its density to sustain forces to resist fracture. Z scores, on the other hand, those are going to compare the results from the individual's imaging to age, sex, and ethnicity matched population. So these scores, the Z scores, are utilized more when there is a diagnosis of secondary osteoporosis in premenopausal women, men under 50, as well as pediatric patients. In these cases, the individual's density needs to be compared to what it would be if the comorbidity causing the deterioration did not exist. That's why the Z score is utilized with more so with secondary osteoporosis to look at an individual who does not have those same comorbidities, but is at the same age point in their life, same gender and ethnicity. What does each standard deviation change on the T score represent? The T score is that value we just discussed that's utilized to diagnose primary osteoporosis when analyzing the DEXA mineral density testing. It compares the individual scan to that of a young, healthy adult of 30 years old with maximal bone density. That score would be equivalent to a 0. So that 30-year-old with healthy bone would be a 0 score. Each standard deviation that we look at away from that 0 or any change in bone mineral density, each single standard deviation is equivalent to a value of 10 to 12%. When we look at the integrity of the bone, someone who has a bone density that is a 1, that means their bone density is 1 standard deviation better than that 30-year-old. This means their bone density is 10 to 12% better than that bone integrity of the typical 30-year-old. What we're concerned about today is that individual who is moving towards osteoporosis. In that case, our expectation would be that their bone density is going to be less than that of the 30-year-old. In which case, when we look at the standard deviation and the changes, when we consider it as a number line, they're going to be moving in that negative direction to a less than 0 value. So someone who has a score of -2 on their bone mineral density, that would mean they're 2 standard deviations less than the 0, which means they're 20 to 24% less quality of their bone compared to that typical 30-year-old. So that's how those standard deviations are utilized. When diagnosis is made and classifying bone integrity, they talk about it as those whole number values 1 to 1.5, 2.5, and positive and negative values. Each of those then correlates to a percentage less of the bone quality. Osteoporosis is diagnosed when the individual has that T score of less than or equal to a -2.5, indicating that their bone is significantly compromised and at risk of fracture. Does long-term omeprazole increase risk of osteoporosis and fractures? Proton pump inhibitors such as omeprazole are prescribed to manage gastrointestinal disorders, including gastroesophageal reflux disease and peptic ulcers. These may be comorbidities that our patients present with, regardless of whether we're treating them for osteoporosis or for some other diagnosis. The medications are effective in reducing the pain that someone experiences from indigestion and heartburn, and they do that through their inhibitory mechanism. However, stomach acids are necessary to absorb calcium and magnesium that are required to create that strong, healthy bone matrix. Also, these medications appear to impair parathyroid hormone metabolism. And we know that plays a role in regulating the withdrawals from the calcium reservoirs of the bone. So we have multiple factors here of how that omeprazole use, while it's beneficial for the gastrointestinal symptoms, it could potentially impair bone integrity. Long term, high dose proton pump inhibitors may increase the risk of osteoporotic fractures, particularly in the spine, is what the research seems to be indicating. It's theorized that the proton pump inhibitor related bone fragility might be related to the impairment of the repair mechanism for bone stresses that occur from daily life, that the bone is just not equipped because it doesn't have the resources it needs to redevelop that healthy bone matrix. And then it becomes weak over time, with the individual at risk for those fragility fractures. The research also says that further studies are needed to really quantify and qualify what the actions are and to see what the real risk of fracture is and how much it is increased for these individuals. It is something for us to consider when we're reviewing patient medications, to note if these are part of what the patient's taking. Consider that along with other risk factors that they are presenting with, so you can have a comprehensive picture. Particularly our patients with gastrointestinal comorbidities, there might be an opportunity to incorporate more osteogenic exercise when we're developing our exercise programs and our discharge plans for them for whatever diagnosis we're treating them for. There was a study in 2021 that was done in Turkey, and they were looking at osteoporosis development in individuals who were taking omeprazole long term, and they found that that mandibular impairment of the bone quality that we've discussed already, that there is some relationship there. They were noticing that individuals taking proton pump inhibitors were already starting to show changes in their mandible, in both the trabecular and the cortical bone, demonstrating that there may be some merit to the concern over the detrimental effects of these medications on the bone microarchitecture, while it is having a positive effect on managing the gastrointestinal symptoms. What impact does spasticity have on bone health in our pediatric patients with cerebral palsy? Disuse osteoporosis, we know it describes that bone loss due to skeletal unloading that can occur for many different reasons. It may just be local unloading with fracture immobilization during healing, or more systemic and long term unloading in individuals with mobility impairments, due to prolonged bed rest, spinal cord injury, or cerebral palsy, as you're asking about. This can occur in both pediatric as well as our adult patients, so it is something to consider. Looking at the spasticity specifically that you're asking about, spasticity can contribute to reduced gross motor function in children with cerebral palsy and can limit physical activity, reduce the weight bearing activities that they're participating in. And the development of osteoporosis, particularly in non ambulatory patients with cerebral palsy, does become a concern even when they are at younger ages. The individuals may demonstrate insufficient bone growth and mineralization during those childhood formative years for the bone. And then as they age, they're also at risk for the development of primary postmenopausal and age related osteoporosis. Combine that with the fact what other medications they might be on or what other comorbidities and risk factors they have, all of this together can increase concerns over the development of osteoporosis. Looping back to your specific question about spasticity playing a role, I hadn't come across any specific research that said spasticity directly impacts the development of osteoporosis. Thinking about it, when treating our pediatric patients with cerebral palsy, there are some additional considerations that we can have when developing our exercise programs. In that population, vitamin D deficiency is common, which can increase the risk of developing osteoporosis and subsequent fracture risk. Multiple factors can contribute to that vitamin D deficiency, including limited outdoor sunlight exposure, feeding difficulties, poor nutrition. So, when we look at it this way, it provides some additional opportunities when we're developing our comprehensive programs as a team: PT, OT, speech, dietitians, the physician. That altered muscle tone can precipitate swallowing difficulties. Maybe there are challenges with lip and tongue control or head control that are limiting the ability to intake food, and that can result in malnutrition, setting the stage for the development of osteoporosis because those components of vitamin D and calcium may not be bioavailable for good bone architecture. Maybe also consider, do you need to address managing the spasticity for positioning during feeding? Is adaptive equipment and training needed for the patient or the caregiver to allow for better feeding? When we look at outdoor sun exposure, are we incorporating car transfers and appropriate wheelchair prescription to encourage more outdoor activity and sun exposure? So I like your question because it gives us another opportunity to get creative and expand our thinking on how we can be mindful of the osteoporosis risk and incorporate it into the interventions that we are already doing to assist that patient.